carefully at the middle phalanx of the same digit. Okay. So the cortex is maximally thickened in the region of the shaft. Okay, so this is actually the white part is actually the thickened cortex. This is a normal finding, and as we move towards the head and the base, the cortex thins out. Okay, so this is a normal finding which you see. You can even appreciate it here as well. So this is a maximally thickened cortex at the shaft. Okay, it spreads and thins out towards the head and the base of the phalanx, and this yellow part is actually the medullary cavity. Okay, so what we are appreciating here is on this end, the cortex is absolutely fine. Okay, but you're not able to see the cortex on this side. Okay, but there are no aggressive features as such which you are able to see. Okay, it's kind of a smooth concave defect with significant thinning of the cortex which you see on the this side. Now we can see that this would be your ulnar aspect and this would be your radial aspect. Okay, so basically what we are dealing here is with the abnormality on the radial aspect of the shaft of the distal phalanx. Okay, so but what is normal here is the medullary cavity is absolutely normal. There is no lytic lesion which you see. Okay? There is just an impression which is smooth, kind of a smooth concave impression on the radial aspect of the distal phalanx, along with significant thinning of the cortex at the level of the shaft of the distal phalanx. Okay. So the lateral view confirms that there is no lytic lesion as such. Now let us move with the ABCD approach we should be following for every bone. That should be in your mind. So A is for alignment. So overall alignment is same. The ray is absolutely maintained, no dislocation. All the joints appear congruent. So there is normal axial alignment both on the AP views as well as the lateral view. Now we have to go. No, there is no subluxation of the AP. The ray is absolutely maintained. So how do you describe that? You will say it's a focal, smooth, concave scalloping of the radial cortex of the shaft of distal phalanx. There's uniform cortical thinning, which you can see. Okay. So the cortex here is appreciable as much as only at what is appreciable at the head and base. So it's actually thinned out. It's uniformly thinned out. It should have been like this, but it's uniformly thinned out. Okay. So as such, you will see that the cortical continuity is maintained. Okay. Why I'm saying that? Because there is no step off which you can see. Okay. Otherwise, if there would have been some invasion or like a kind of an infiltration or some fracture, you would have noticed any step off here. Okay? But it's kind of a smooth continuity. It's just that the cortex is actually thinned out. Okay. And very important, the underlying medullary cavity shows preserved trabecular pattern with no evidence of any intramedullary lytic or sclerotic lesion. No fracture line where we are able to identify, and there is no periosteal reaction. Okay, so all these wordings I want to be there in your report. Okay. Next, joint space. Obviously, it's normal. Okay. No joint space widening, narrowing, no osteophytes. So there is nothing, no features of any arthritis here. Okay. Absolutely correct. The first one, you see some differential radiopacity in this region, very subtle one, but you can appreciate that. Okay. So there is some soft tissue lesion or a mass which is causing scalloping of the, most likely it is causing scalloping of the subjacent part of the shaft of the distal phalanx. Okay, but we do not see any calcifications in that. Okay. We do not see any phlebolith. We do not see any gas locules. Okay. We just see a differential soft tissue radiopacity adjacent to the area of scalloping. That's it. Okay. No additional features are there we can see in the soft tissue. And very importantly, in extras, you do not see any foreign body implants, and you do not see any periosteal reaction. Okay. So this is just a normal radiograph, and this is the radiograph of our patient. Okay. So you can see that this is how the cortex should appear on both the sides. And in this, you can see that there is a smooth concave scalloping of the radial aspect of the shaft of distal phalanx. Okay. So how do you summarize that? So we summarize all the findings, and very important, what are the negative points which you need to know? That there is no cortical breach. Okay, so there are no features of cortical destruction. Okay, so it would have been something like this. It would have been an infiltrative lesion. Since it's a smooth thing, so it's actually some benign lesion which is causing a pressure remodeling of the subjacent cortex. Okay, so there is no loss of continuity, there is no permeative pattern. Okay, there is no overhanging or undermined cortex. Okay, so can you tell me where do we see the overhanging cortex sign? Okay, and by saying that we are not having any overhanging cortex, what we are ruling out? Yes, what we are ruling out is tophi of gout. Okay, because those are the ones which present with juxta-articular erosions, but okay, the scalping can be similar. Okay, but we need to have some overhanging cortex sign. Okay, because it's actually erosion. Okay, so no features of periosteal reaction, no features of intramedullary involvement, no features of invasiveness. So we see that there is some benign soft tissue abnormality which is causing a pressure remodeling of the distal phalanx, the shaft of the distal phalanx. Okay, this is just to there are two terms which you should not confuse. One is your end ostial scalloping. Okay, you must have used this term in the tumors, in the intramedullary tumors. Okay, and one is your external pressure induced scalloping. Okay, what we are talking right now. Okay, so this is just very basic. Okay, so the inner lining we call it as the endosteum, outer lining we call it as the periosteum, and in between that we have the cortex. Okay, cortex is maximally thickened at the shafts, thins out at the head and bases if you're talking about the phalanges, and if you're talking about the long bones, it again thins out like this. So this is the normally thickened cortex at the shaft. It normally thins out at the proximal ends and the distal ends. Okay, or you can say at the articular end. Okay, so I hope it's obviously clear. I suppose you know the difference between the endosteal scalloping and the external scalloping. Okay, so we need to have some, I'll show you the example. So we need to have some intramedullary lesion. Okay, so that will be causing the thinning of the cortex from the endosteal end. So that is why we call it as endosteal scalloping. Okay, like this. I suppose this is a case of fibrous dysplasia. So this is a normally thickened cortex. On this side, you see the cortex is thinned from the inside maximally. So this is diffuse endosteal scalloping, or you can say diffuse endosteal thinning. And this is your focal endosteal scalloping. Okay. So this is just for your differentiation that we are not here talking about the endosteal scalloping. We are talking about something which is outside of the bone, and then it is causing a pressure over the outer cortex, causing its external pressure induced scalloping. Okay, so like this is an R case, so it can be smooth, and then for example in cases of chronic osteomyelitis, okay, this can be irregular. We can have sclerosis also along with that. Okay, so depending on that, what kind of soft tissue abnormality is there? Like it's an aggressive abnormality, so you will find features such as irregular jagged destruction. You can even have breach of the cortical cortex. Cortical thickness will be focally destroyed maximally. You will have presence of some periosteal reaction depending on whether it's a benign or an aggressive abnormality. You can even have intramedullary involvement as well. Okay, so it will be kind of a rapid destructive process. And when we are talking about a smooth Scalloping, we are talking about something called as benign indolent, or you can say it's a slow growing process. Okay. So it's a smooth pressure erosion of the outer cortex, which is suggestive of an indolent extrinsic or a soft tissue. So by extrinsic, we mean here extramedullary process, or you can say extra osseous kind of thing. You can say an extra osseous process.